This
also in
conference
academic
will
time,
now be recorded.
and also in a day-to-day clinical practice, and that is diabetic retinopathy. So here's a patient, a 65-year-old gentleman, has present TB with the chief complaints of diminution of vision in his both eyes. And when he asks question to the patient, he asks about the duration. He says he has been loss of vision since several months. The onset, he said, is gradual. It's a painless type of loss of vision. There is no preceding history of trauma, but yes, he has a systemic illness. So when you have this gradual painless loss of vision, we always think of many factors like diseases like differential diagnosis that come under like age-related cataract, open angle glaucoma, refractory error, age-related macular degeneration, diabetic retinopathy, sometimes hypertensive retinopathy or brain occlusion also. When you look at the fundus examination, this is what you see. You see a lot of tortuous vessels, a lot of hard rates and areas of superficial and deep areas of hemorrhage. So this on fundus examination, and also the patient gives a history of diabetic retinopathy in several years, and you come to the conclusion that this patient has lost his vision due to diabetic retinopathy. So what are the risk factors of diabetic retinopathy? Do all diabetic patients have diabetic retinopathy, or some of them, or many of them? So it's one of the factors is duration of diabetes. If you have diabetes like type 2 diabetes, you have different, depending on different studies, like if you have diabetes for 20 years, then around 80% will have some form of diabetic retinopathy. So duration is a factor, and that is one factor that we can never control. We can control the blood sugar of the patient, but then because of the duration, as the patient has the disease for a longer duration, they are very likely to develop diabetic retinopathy. So all diabetic patients have a risk factor of diabetic retinopathy, which increases as the duration of the disease increase. The next of this is poor glycemic control. As you know, patients who don't have good blood sugar control will develop retinopathy much earlier, and they will have much more aggressive retinopathy. And now we also know that they will also not respond very well to treatment. The third is hypertension. Diabetes and hypertension, like Wikipedia trial has shown that actually they go hand in hand and actually increase the risk of retinopathy more than 50%. On conversely, if you control hypertension in a diabetic patient, it will also help you control the retinopathy also. So each worsens the next. Then the diabetic patient also will have nephropathy as a result of diabetes, and many times the nephropathy and retinopathy happen very in close proximity because they are pathologically same. Likewise, pregnancy for diabetic patient who is pregnant, then again the metabolic changes in her body due to a pregnancy, and then retinopathy can worsen. If a pregnant woman has develops diabetes only due to pregnancy, then the risk factors are not high. But if the patient was a diabetic earlier and is now pregnant, then the risk of diabetic retinopathy becomes much more severe. And apart from this, there are other risk factors like hyperlipidemia, like lipid cholesterol, triglyceride elevated, or the patient is anemic, or obese, or even smoking is also an important risk factor for diabetic retinopathy. So all these factors play together to worsen the chances of having retinopathy in diabetic patients. So there's pathogenesis. We can describe pathogenesis in two ways. One, as you can see in the picture, is related to, on the left side, the red part is due to occlusion. The other is related to leakage. The most important thing to remember is diabetic retinopathy. It's a microangiopathy. So large vessels of the retina are not involved. It's the smaller vessels, that is the arterioles, that's the capillary, and the venules that will develop the disease due to the diabetes. The factors related to occlusion is like there's a thickening of basement membrane, endothelial cell damages, even the content in the blood, like the RBCs change, the platelets become more sticky, and these can lead to formation of small occlusions in these small vessels. Or on the other hand, the vessel wall becomes weak because the pericyte that actually support the venules and the capillaries actually get damaged, and slowly because of that there's a weakening of the wall, and as you can see, this is an aneurysm. And these aneurysms develop and they actually break down and cause a leakage. So if the leakage happens, as we can see here also, we talked earlier, you can see aneurysms here. You can see aneurysm, and when these aneurysms break, then the contents in the blood come outside, and they come in terms of retinal edema, where this fluid is there, dense hydroxylate, or hemorrhages may occur. So you can see a typical case where there's a lot of leakage, you can see lots of hemorrhages, what you see in the center is a lot of hard exudates. So this happens due to leakage. The other aspect we talked about was occlusion, and it's the same thing. The vessels get occluded. Now the another with the retinal vessel is that it's an end vessel, so it doesn't have good collateral circulation. So anywhere is occlusion, like in other parts of the body, when one part of the vessel is occluded, then we have a collateral circulation. That is a normal healthy vessel from nearby, which comes and connects to the diseased vessel and then helps to maintain the supply. But in retina, because it's an end arterial or the end vessel, this doesn't happen. Collateral circulation is very poor. So the body compensates by forming new vasoformative substances that cause the formation of new vessels. However, the new vessels in retina are actually counterproductive and are very risky. So whatever we develop as a cause of new vessel proliferation, like diseases in the eyes, in the anterior segment, or what you more commonly see is in the posterior segment, vessel proliferation, which occur. This causes more harm to the retina, and actually in the long run, as we'll see, is a big risk factor for loss of vision. So as a cause of occlusion, there is formation of new vessels that are counterproductive and then lead to blindness in the long run.
Sir, sorry to interrupt you, but
yes.
Sir, can you adjust your microphone? We are hearing some kind of echoes.
Echoes. So maybe I'll try connecting with the other. Just a minute. Let me use my iPad. Maybe I can do it.
Okay, can you hear me now?
Sir, there is echo. Still
Now?
echo.
Is it okay now?
Sir,
Just a minute.
echo is the minus, repeatedly.
Is it okay now?
Yes, sir. Yes, sir.
Already ठीक है. Okay, we again continue. So this is what we see as a result of new vessel. New vessel formation, as you can see in this picture. There's a lot of new vessel formation. This is called in the disc, optic disc. You can see all these proliferative new vessels that have occurred because there was a occlusion. Likewise, there is a new vessel.
Excuse me, sir.
ठीक छ?
Excuse me, sir. Sir, video आइरहेको छैन अहिले. Presentation आइरहेको छैन sir अहिले.
Okay. अहिले ठीक छ?
हजुर ठीक छ sir.
ठीक छ है. So we can see new vessel formation. As you can see, this is the new vessel formation in the optic disc that we call a new vascularization of disc, NVD, and also new vessels along the arcade that is defined as an NV or a new vessel elsewhere. Again, you can see here this is a big NVD. So this is all occurring because there is an occlusion of the vessel, and the body made new vessels, and these are all again you can see in the iris also. It also hits the anterior segment also. So the classification we can see in the diabetes is on basis of the proliferation or non-proliferation. We have mild NPDR, moderate NPDR, severe NPDR, and proliferative. Proliferative is what we saw earlier, is the formation of new vessels. The patient also can has diabetic macular edema. It is classified into central diabetic edema if the central 1 millimeter is affected, or a non-central diabetic edema, that is central 1 millimeter of the macula is not affected, the periphery part of the macula is affected. So NPDR is very basically what we call retinal microvascular changes, and this is confined to the retina. So there's lots of microaneurysm that we saw, retinal hemorrhages, lipid exudates, cortical spots, capillary non-perfusion, microedema, venous calcium changes, or intraretinal microvascular abnormalities. So a typical patient having an NPDR, as you can see, lots of hemorrhages are there, some cortical spots also, some changes in the vessels, slightly more tortuous. So microaneurysm are actually the first signs of indicating of a diabetic retinopathy. Usually occurs if you see it starts in slightly temporal to the macula. So usually if you don't see any diabetic changes around the macula, sometimes we assume that maybe the periphery is not so bad. The other changes would be hemorrhages in a deeper or superficial layers. Even the choroid is also affected, although it's difficult to see while we're doing a fundus evaluation, and cortical spots or succinate hard exudates are also seen. So let's see, you can see an early stage diabetic patient, you can see small dots, and these are actually aneurysm. This can also be hemorrhages. So if you see a red dot in the posterior pole, it could be either a hemorrhage or an aneurysm. This you can see is a succinate hard exudate in the center. And again, this is a leakage as we talked. The aneurysm ruptures and the contents in the blood goes into the macula. And in this case, because the fovea is affected, we have a macular edema. Likewise, in this you can clearly see a small aneurysm in the center, and then hard exudates are spreading around this. So the leakage has occurred from the center, lots of hard exudate, and some fluid is collected over here. And FFA is even more helpful. This is a fundus fluorescent angiogram, and because FFA lights everything up, a very small lesion that you may not see in fundus examination actually lights up in an FFA, and you can see clearly lots of small dots. And this actually hyperfluorescent dots are aneurysms. If the dot is black, then it's an hemorrhage, whereas in aneurysm, it's a lighted up small hyperfluorescent dots. This is a very high magnified FA. Here you can see small knobs like openings, and this is the pictorial drawing we saw earlier. These are small outpouching in the vessels, which is a aneurysm. Then hemorrhages, as we talk, a dot plot hemorrhage or a flame-shaped hemorrhage. A flame-shaped hemorrhage is in the superficial part of the nerve fiber layer, and because of the structure of the nerve fiber layer, it spreads around and gives this typical splinter-like hemorrhage. Whereas if the vessel leakage occurs deeper in the retina, like inner nuclear layer, outer plexiform layer, the blood doesn't get a chance to spread, so it gets accumulated in a particular area. That's why it has a dot or a blot appearance. So you can see this is a typical flame-shaped hemorrhages, and these are dot blot hemorrhages. So usually these hemorrhages occur in the outer plexiform layer. If you see the anatomy of the retina, you have vessels in the superficial layer or the outer plexiform layer. So these are the areas, either you have hemorrhage over there or in the deeper layers, depending. And there are many a times affinity in the macula also. That's why this patient develop macular edema. So these are all leakages from the aneurysm. Again, you can see a patient, you can see a large dense exudate in the center, and you can see a circumcinate pattern. That is a round pattern. That is, so the origin of the hemorrhage must be over here. You can see some dot hemorrhages, probably an aneurysm leaked, and because of that, the hemorrhage was spread. And this patient, you can see a dense hard exudate in the center. So these hard exudates are quite resistant. They do not go away that easily. So it's not a good sign if a patient develops so. Same ways, you can see a lot of hard exudate here in this picture. Apart from this, we also see abnormalities in the veins. So we talked about that it's a microangiopathy, but certain signs also develop in the vein, and this occurs in terms of venous beading, looping, or venous sheathing, or focal narrowing. So these signs, venous signs, actually are indicator that our ischemia is there, and the patient may develop proliferative retinopathy very soon. So beading is like typical beads you see in like a necklace, if you see, or like a sausage shaped pattern. You can see over here, like a beading over there, just like a necklace over there. Here you see a sausage shaped pattern. It's like a loop. If you see this sign, you can assume that the patient is going to either already gone into proliferative retinopathy or about to develop. This is not a direct sign of proliferation, but it's a sign of ischemia. So again, we talk FFA gives a very good image, lights everything up. You can see a nice sausage-shaped pattern. So this is the arteriole, the vein. You can see some lamellar circulation, and these are actually the capillary drop out areas. So IRMA is intraretinal microvascular abnormality. These are telangiectatic channels between arterioles and venules. Some people call it an intraretinal neovascularization, and it's also a highly powerful predictor of the development of PDR. So here you can see venule and small arteriole. You can see a small connection going from one to another. So it's more like a small collateral circulation. Some say it's like a new vessel formation, but if you see certain area, then you can say that a lot of ischemia is occurring in the retina, and the patient either has already developed proliferative retinopathy, or if the patient has not, is very likely to develop proliferative retinopathy soon. Again, this is venous bleeding, a lot of sausage patterns you can see, and this all are IRMA. Again, same over here, you can see IRMA, you can see this is arteriole, a small venule, and then you can see a collateral circulation developing between them. So this is all signs of non-proliferative diabetic retinopathy. What we talked about was hemorrhages, we talked about microaneurysms, heart exudate, cottonwool spots, and also IRMA and venous bleeding. The next stage is proliferative retinopathy, the pictures we saw earlier, and these are basically what we saw in the early picture, also formation of new vessels along the vessels. So same way we talked about earlier, you can see an NVD over here, new vessel has formed in the disc. NVD is actually not a good sign, it's a very bad sign. It says that the patient had a lot of ischemic changes in the retina. It's not a good prognostic sign. Or you can see a fan-shaped new vessel proliferating in the periphery, or what we talk neovascular elsewhere, or NVE. Again, this is another sign of proliferation. So same, you can see simultaneously an NVD and an NVE. So if you compare this to the IRMA, in the IRMA it was not crossing the vessel. This one you can see is very haphazard, is crossing the vessel, going different directions. The next stage after this formation new vessel is formation of vitreous hemorrhage or traction. The vitreous hemorrhage is basically these new vessels rupture and then they cause a lot of bleeding. This could occur primarily from the new leaky vessels, or the patient develops a vitreous detachment. Actually, these new vessels grow from the through the ILM into the vitreous and get pulled into the posterior hyaloid. So the vitreous detachment, when it occurs, it pulls these vessels out, and there's a massive avulsion and a lot of hemorrhages or bleeding occurs in the vitreous cavity. So in this patient, you can see there is a NVD over here, and you can see a lot of vitreous hemorrhage here, like a subhyaloid hemorrhage committed over here. So this is a state of vitreous hemorrhage, which is after the proliferation. Again, similarly, we see in the typically both pattern, this is a subhyaloid hemorrhage. That is, the hemorrhage is between the retina and the vitreous detached vitreous cavity. Likewise, we have tractional detachment, and tractional detachment happens because this new vessels, the NVD and NVA, later on, initially it's vascular, but later, as they regress, they become this fibrous proliferation. And we talked about that the new vessels actually go and attach to the posterior vitreous phase. So when the gel contracts during PVD, this tractional actually has more cause of strong pull on the retina, leading to tractional retinal detachment. So when the PVD pulls, it either leads to a vitreous hemorrhage, or if there is strong tractional attachment, then it leads to a tractional detachment. So these features, vitreous hemorrhage and tractional detachment, happen in advanced stages of diabetic retinopathy. Likewise, you can see here, there's a lot of traction over here, and these are just new vessels that have regressed to form traction. Same you can see here. So if you see a patient in advanced retinopathy, you will always have these features. So again, a B-scan picture, there's a vitreous hemorrhage, some tractions, not so very clear, but there you can see pockets of vitreous detachment, and even the retina has detached bleeding, which is indicative of tractional retinal detachment. Same over here, you can see the patient has NVD, and there's formation of these tractions. Same over here, you can see tractional detachment. So if these structures go uninhibited, slowly they will contract, and when the vitreous also detaches, they will pull the retina out. And another advanced feature we talked earlier also, there's also not only new proliferation of the vessels in the posterior segment, but even the anterior segment is hit. So they will form proliferation in the iris. Slowly they will grow over the angles, and they will occlude the angles and cause what we call a neovascular glaucoma, which is a very serious condition and very difficult glaucoma to treat. The other way the patient loses vision is due to macular edema. So you can see in the books there are certain classification like clinically significant macular edema. This is based on ETDRS classification. That is, in the central 500 microns, is there an area of retinal edema, or within this area whether there is area of heart exudate, or a large area of 1 disc diameter edema covering and 1 disc diameter area if it's overlapping also. These are labeled as CSME. And what CSME actually means that this patient is likely to lose vision because of macular edema and needs to be treated. But the recent eyes we are using, the classification we are most using now is based on the International Council of Ophthalmology classification of DME, and it has actually defined it very easily: central involving or non-central involving. So this you can see is a central involving DME. There is a hard exudate in the center 1 millimeter of the macula, whereas here you can see the fovea is paired. There is a macular edema, but it's away from the center. So this is a non-central involving macular edema. So this causes severe loss of vision, whereas in this stage the patient will not have vision loss now, but may have in future. Also, because the admit of OCT or the diabetic macular edema can also be classified on base of the OCT findings. We have diffuse retinal edema, cystoid macular edema, a posterior highlight traction, subretinal or serous detachment, or a transretinal detachment based on the OCT findings. Likewise, if you do an FFA in a diabetic edema, again you can classify differently, like the patient may have focal edema, diffuse edema, ischemic. This one you can see is an ischemic macular edema. Here you can see the vessels are occluded, and the central foveal avascular zone is much enlarged, and we can see adjacent in areas also. The capillary dropout area is there. So this patient has an ischemic macular edema. This also is not very responsive to treatment, and usually we do not treat this so much because the response is not so good. Or the patient may have a mixed edema where there is a combination of leakage as well as ischemia, focal, and diffuse happening altogether. So how do we screen for a patient? So if the patient has no diabetic retinopathy and mild NPDR, you can call the patient to follow up in 1 to 2 years. If the patient has moderate NPDR, then you can follow up the patient 6 to 12 months. Severe NPDR, you can need to follow much earlier, that is less than 3 months. And PDR, even much more earlier, less than 1 month. Likewise, if the patient has a non-central DME, you can follow the patient in 3 months, or central DME in 1 month. So if the patient has a very sight-threatening condition like severe NPDR, PDR, or central DME, then we need to follow the patient less than 3 months. Also, when making this patient come for screening or next visit, you need to account the blood sugar of the patient. So let's say the patient has moderate NPDR, but the blood sugar is very, very high, then don't go for this 6 to 12 month guideline. You may need to call the patient earlier because he may progress very quickly in between your follow-up. So how to screen the patient? Obviously, the typical protocol we do in a regular eye examination: do a vision acuity, best corrected vision, intraocular pressure, have a slit lamp examination to see the anterior segment where the patient has cataract. A lot of diabetic patients will have cataracts earlier also. And obviously, we need to always do a dilate fundus evaluation because we cannot miss the findings. So if you examine the patient without dilating, then you may miss a lot of subtle findings. So we always adhere to a dilated fundus examination. Likewise, you can also do a fundus photography. Fundus photography is a good means of recording the patient. So if the patient is coming on follow-up, then comparing the fundus picture is as a very good way of comparing how the patient has progressed or not. The option to other is to do a fundus drawing also, which we do, but fundus photography is even much better. And likewise, we may also order an FFA, and this is for the patient has severe NPDR, PDR, and DME. And what I said earlier, with an FFA picture, you can see things much more clearer, and you can even small findings that you would have missed clinically, you can see with the FFA, and also capillary dropout areas like we saw in ischemic diabetic macular edema. These things will not be able to diagnose clinically. We need the help of FFA. Likewise, if the patient has also a diabetic macular edema, you can also use OCT. Now we even have OCT angiography in some centers, so you can even use an OCT to see the central part of the macula, like you see in FFA. Also, make sure that you check the HbA1c of the patient. The patient needs to have a HbA1c less than 7. If there is less than 7, it is controlled. More than 7 is uncontrolled. Likewise, you need to check the blood pressure of the patient. It should be less than 140/90. Just a moment. So also always make sure see the glycemic status of the patient while keeping in the diagnosis in mind. So the treatment modality, you might see many things, like we do retinal lasers in terms of focal, grid, PRP laser, or some pattern laser or Pascal. Intravitreal anti-VEGF can also be used, that is Avastin, or sometimes the patient requires surgery. So this is a typical grid laser pattern, and what this is a type of a macular laser. So you can see a lot of spots around. In this almost a circle has been made around, and you can see this patient has macular edema, a lot of hard rays and hemorrhages are there. So a grid laser has been done. So earlier this is a shows like a bright spot, and later it gets pigmented, and you will see a blackish kind of a scarred area in the macula. Although we even more commonly do is a focal laser. Grid laser we are doing less and less now. We do focal laser also. So here you can see two circumscribed hard exudates. So the aneurysm is somewhere here. So you do give a laser over in these two areas, and slowly this hard exudate will absorb. So you can see now this is a follow-up. You can see this pigmented area, which is a old laser marks. This is a PRP laser, pan-retinal photocoagulation. In this area away from the macula, a lot of large spots are given. So in a focal laser, we use slightly smaller size spots, 50 to 100 microns, whereas in in PRP, we will give a much larger spot, 3 to 500 micron size. So indication of pan-retinal photocoagulation is in a proliferative diabetic retinopathy, or even now we laser earlier to that stage, that is in case of severe NPDR, whereas grid laser or focal laser is given in diabetic macular edema. Again, you can see a PRP done. You can see a lot of spots here. You can see the very nice pattern laser, and this is a different kind of laser called pattern laser. So this laser, what we'll do is form a scar, and it'll slowly the stimulus for the formation of new vessel will disappear, and also the formed new vessel, that is NVD and NVE, will regress. Likewise, we also now use anti-VEGF. You might see a lot of patients following up with like injection Avastin, bevacizumab, ranibizumab, eflapegrastim, etc. And these are multi-intravitreal injections we give in India, but the main indication is for a diabetic macular edema, and that too central involving diabetic macular edema. And also we can use in proliferative diabetic retinopathy sometimes, and also an adjuvant to surgery. Like let's say the patient has vitreous hemorrhage, we plan for surgery, we can give Avastin before or immediately after surgery also. But the main gold standard treatment now, it has become a main treatment modality for diabetic macular edema. So laser was earlier the gold standard. Now in diabetic macular edema, now because of anti-VEGF, it has taken over. Apart from anti-VEGF, we also use corticosteroid also sometimes, like triamcinolone or dexamethasone also used. And the last stage is many a times is vitrectomy, and indications of vitrectomy is dense vitreous hemorrhage, tractional macular detachment because of the traction, or the patient has having recurrent vitreous hemorrhage despite laser, or patient has a dense epiretinal membrane or a vitreomacular traction also. So usually vitrectomy is not the first line of treatment. Usually if the patient comes to like a dense hemorrhage, then we usually wait 1 to 3 months before we decide for a surgery. But it's a very dense hemorrhage is not resolving, then conservative margin is abandoned and we go for a surgery. Likewise, same way if the patient has a fractional macular detachment of early onset, also we need to do vitrectomy. But the output is not so good because these cases are already bad cases. So usually these are much for vision saving rather than vision improving surgery. And some patient maybe 50% or less may not improve so, or may lose the vision also in this stage. So many strategies have been legal overall, like track strategy. That's the advice we give to the all diabetic patient: take your medication, maintain your ideal body weight, add exercise, control your sugar like HbA1c, BP, cholesterol, kick off your smoking habits. So these are just general habits for all diabetic patients, because of control of the sugar, good healthy habits, and also the control of the risk factors is the best strategy to prevent, because prevention is again in retinopathy the best, diabetic retinopathy the best way to preserve the vision. Once the patient develops diabetic macular edema, proliferative diabetic retinopathy, then the vision improvement is much less, and the patient has more than 50% or around 50% chance of losing his vision. So likewise, you can see, let's say we examine this patient OPD, not structures in the vessel. You can see some hemorrhage. So this is around like a mild NPDR. This patient, you can see lots of hemorrhage, and you can see fine vessels over here. This is actually here has already developed a new vessel. So this is a proliferative diabetic retinopathy, and also you can see a lot of hard within center. So this patient also had diabetic macular edema. So here the treatment modality would be PRP laser for this proliferative diabetic retinopathy, and for the diabetic macular edema, first time we'll go for Avastin injection or anti-VEGF injection, and later we may supplement with laser also. But despite this patient treatment in this patient, the vision might not improve much, but we need to save his vision. Again, you can see in this patient also here, the patient has NVD, and because this is a proliferative diabetic retinopathy, we need to give an extensive laser. That is a PRP laser here. And this patient, you can see, in spite of having, these are all laser marks, you can see they are pigmented, usually have black pigment margins. And despite the laser, this patient had NVD, and you can see a bleeding over here. He has developed vitreous hemorrhage. So, this patient will not require a vitrectomy as of now. You probably do more lasers, give avastin injection if that is required, and the vitreous hemorrhage usually resolve. But if the vitreous hemorrhage doesn't resolve and there are lots of hemorrhage occurring time and again, then we need to do a vitrectomy also. So again, the same thing. You can see the patient has a lot of diabetic macular edema, hard exudate hemorrhage is there, some tortuosity is there. I can't see a new vessel over here. So this is severe NPDR. Again, in severe NPDR, we now, earlier the guideline was to do PRP laser only if the patient has a proliferative retinopathy, that is a new vessel formation in disc or elsewhere. But now, even if the patient comes in the stage of severe NPDR, we again do laser. And because the hard exudates are there, the patient also has diabetic macular edema, and we need to give avastin injection, or in future may require some additional laser also. So any questions you want to ask?
Thank you for the session, sir. This was very informative for all of us, especially for the second years. If anyone has any questions, you can ask him.
You can write in the chat box also. I'll just read your question and I can answer. So one thing I think maybe I missed over here is the 4-2-1 rule, and 4-2-1 rule is the, I think I lost that, is actually the diagnosis of severe NPDR. So 4 is hemorrhages in 4 quadrants. That is hemorrhage, not just one hemorrhage. To say one quadrant is involved, you need at least 20 hemorrhages. So just a rough, you don't have to count, but it's a rough way. So if it has 20 hemorrhages in one quadrant, and then we can say one quadrant is affected. So if 4 quadrants, the superior, nasal, temporal, inferior, if 4 quadrants are involved, then the patient has severe NPDR. Or two. So if the patient has venous bleeding involving 2 quadrants, then again they're labeled as severe NPDR, or intraretinal microvascular abnormalities in 1 quadrant. If any of the 3 signs are there in this 4-to-1 rule, then the patient is labeled as severe NPDR. If the patient has severe NPDR, then chance of having a PDR within 1 year is said to be roughly 50%. So earlier, what we talked, we were doing laser in stage of proliferative retinopathy, but now if the patient is diagnosed as severe NPDR, we usually start laser in that stage only. So Manoj, PKC, what do you mean by PKC? Okay, but I actually, yes, some newer modality treatment is there. I don't have actually much information about protease kinase C. So one of the other thing is diabetes. If you follow the newer theories, is like one is the newer theory says apart from microvascular abnormalities, there's this neurodegeneration and also inflammation. So protein kinase C is related to the inhibiting the inflammation over there. But there are many trials over there, but maybe I can't tell you much over here because I've read them quite some time back. But yes, like steroid also, that's why apart from anti-VEGF, steroid has additional role, because not only anti-VEGF, but it will also help you suppress the inflammation. Neeraj has asked us about how to do fundoscopy. Yes, now this is a big challenge for us, doing a fundoscopy in a dilated patient. And because the proximity of the patient here is there, so don't use a direct ophthalmoscope. Obviously, we won't be using them. So we need indirect ophthalmoscope. Now, if you see in teaching hospital, we have actually installed a plastic cover sheet in front of the indirect ophthalmoscope to keep a cover. And while using a lens, keep your distance from the patient. And also after the end of the procedure, also put a glove, because your hand is going to be resting on the patient's forehead. Use sanitizer after you have touched the patient. Clean the lens rim of your 20 diopter lens after you complete the procedure. The other option would be in for future to use the fundus camera also, because there you can maintain some distance from the patient. But definitely a very good question. So, any more questions? Okay. The next, I think, next session I have with you is hypertensive retinopathy, and maybe we can add venous occlusion. We'll have that on Thursday if your schedule is appropriate at that time, around 1 to 2 o'clock, and you can let me know.
So there's another question in the chat.
Okay, another thing. Does anti-VEGF have any side? Yes, anti-VEGF directly usually causes very less chance of having a side effect directly due to the drug, which is a very small dose that's given inside the eye. But you may have a complication as a result of the procedure, and that is because it's given directly in the vitreous cavity. You can have endophthalmitis, which is a very serious infection. Sometimes if you choose the wrong patient also, because the anti-VEGF causes the regression of a new vessel, that also means a more fibrous activity is there. So sometimes they may pull the retina also. The drug itself very rarely causes a direct reaction to the eye, but definitely as a result of the procedure you may develop endophthalmitis or a tractional detachment. So you need to be used with care. But usually we are most of the time using in diabetic macular edema, and it works very well in diabetic macular edema. It also restores the vision of the patient. That's something we were not having with laser. So different kinds of Asta has asked which case do we use different kinds of laser and diabetic. So there are some options like three types of laser, three types of laser we talk in macular. If you're treating macular edema, that would be the focal laser or a grid laser. These are patterns, and then the other one we saw in the proliferative diabetic retinopathy is PRP laser or pan-retinal photocorrelation. And we have different laser mechanisms like a Pascal laser. We saw a pattern laser can be given. Also, the wavelength of the laser may be different. Earlier, we were using red laser, that's 810 nanometers, longer wavelength, has a very good penetration if the patient has a vitreous hemorrhage actually, but causes a lot of pain. Now we are switching to green laser. Green laser is 532 nanometers, and it's much more comfortable for the patient. It gives a mild spot than the red laser, not so deeply penetrating. So the patient is much more comfortable, and we get a very localized. A newer advance is like yellow laser, and yellow laser is very good, as they say, for diabetic macular edema. But despite of that, all three lasers are quite good, and you can use with the same effect in all kinds of patients. The other is also the type of delivery. If you have seen in teaching hospital, we have a still time delivery. You can also use a headset to deliver laser, and if you see in the operation theater, we have an endo laser probe, and that's like a small probe that we take through the incision of through the sclera to go inside and laser. So you can also have a difference in the modality in which the laser is delivered also. So any more questions?
Maybe that's all for today, sir.
Okay. So next session we'll have on Thursday. Is that okay for you?
Okay, sir.
Okay.
Okay, sir.
Okay.
Yes.
Okay. Thank you.
Thank you for this, sir. Thank you.